Hey everyone, so today I'm back with another mock USMLE question. This is going to be question number 16. So the question is, you have an 85-year-old female with past medical history for poorly controlled diabetes mellitus, high blood pressure, hyperlipidemia, and rheumatoid arthritis, who presents to the ED with acute onset chest pain. Patient states that their chest pain started 2 hours prior to presentation. Pain is rated at 9 out of 10 in severity. Patient also states that the pain is sharp in nature, located over the center of the chest without any radiation. Patient denies shortness of breath. Temperature is 37.4, blood pressure 172 over 100, and pulse is 95 beats a minute. On physical examination, patient appears to be in acute distress, holding her chest. An EKG is obtained, shown in figure 1, which I'll show you in a second, and a CTA chest is obtained, shown in figure 2. What is the most appropriate next step in management? So before I go over the options, I'll show you figure 1 and 2, and then we'll discuss the answer. So this is figure 1, the EKG. If you need more time to look at the EKG, go ahead and pause it. Next, I'll show you the CT of the chest. If you need more time for the CT of the chest, go ahead and pause the video. Next, I'll go back to the question. Once again, given this clinical presentation of a patient presenting with chest pain, given those EKG and CTA findings, what is the most appropriate next step in management? Option number 1 is immediate surgical repair. Option B is medically management with beta blockers and blood pressure control. Option C, emergent PCI. And option D, endovascular stenting. And once again, here's the EKG, and here's the CT of the chest. So the correct answer is immediate surgical repair. Now, in order to answer this question, let's just look at the EKG and CTA chest one more time. So on this EKG, it's actually completely normal. There are no ST segment changes. You don't see any T wave inversions. And the reason I included this EKG is one is it helps you rule out that this patient is less likely to have an ACS. But the other learning point from this is just because the USMLE gives you some sort of imaging findings doesn't mean there has to be some sort of abnormality on them. So just remember that if something seems normal, don't waste too much time and kind of trust in your gut instincts. So the EKG once again is abnormal and kind of helps you rule out the possibility of ACS. However, when we come to the CTA chest, there's two things I want to kind of point right to. One is whenever you're looking at the CT of the chest, usually the aorta up here, this is the ascending aorta. And the portion of the aorta down here is the descending aorta. And what we see in the ascending aorta over here is that we see this line here. This is the intima, and remember, actually, the aorta has 3 layers: intima, media, and adventitia. The intima is the layer closest on the inside, right next to the blood. So in this, what we see is the intima has separated from the media and adventitia and formed a false lumen. And what condition does that happen in, where the intima gets separated from the media and adventitia? That's aortic dissection. And with aortic dissection, what you have to know is there are 2 kinds of aortic dissections: type A and type B. Type A aortic dissection happens in the ascending aorta, when the ascending portion of the aorta, the intima gets separated from the media and adventitia. Whereas in type B aortic dissection is when the intima gets separated from the media and adventitia in the descending portion. So once again, type A is aortic dissection that affects the ascending aorta, and type B aortic dissection in the descending aorta. The reason that distinction is very important to make is that the management for type A aortic dissection is immediate and urgent surgical repair, because the rate of mortality in this condition is incredibly high. So it's very important to immediately surgically repair this pathology whenever it's found. The rate of mortality just in 1 or 2 hours approaches upwards of 50%. Whereas that's for a type A aortic dissection. The management for type B aortic dissection tends to be initially more medical, where the first step you want to do is lower the blood pressure. That's the first step. And once again, for type A, surgery; for type B, medical management with lowering blood pressure. So let's look at the options one more time and make sure we're all on the same page. Because on the CTHS that I showed you in figure 2, because it shows the aortic dissection, the correct answer is once again immediate surgical repair. Looking at option B, which says medical management with beta blockers and blood pressure control, once again, that would be the correct answer if this was a type B aortic dissection, which affects the descending aorta, which this is not the case, so we can rule out option B. Option C, emergent PCI. Remember, emergent PCI is the first step in management of STEMI. And look at the patient's EKG, we can likely say that ACS is less likely given that we don't see any ST segment changes or any T wave reversions. And last option, endovascular stenting. Once again, this isn't an ACS, this is aortic dissection affecting the ascending aorta that needs emergent surgical repair. Another point that I want to make with regards to this question is, so in the question stem, I told you a lot of things about this patient. I said patient's an 85-year-old, and I mentioned a lot of different past medical history, including the fact that the patient had rheumatoid arthritis. One thing I want you to remember when you're often reading these questions is the folks who write these questions will often provide a lot of information. It's really important not to get bogged down by the information and focus on what's pertinent. In this question stem, I added the fact that this patient had rheumatoid arthritis. That has no bearing on how you think about this question, how you answer this question. So it's really important to know when information is useful and when it's useless, and don't get bogged down by useless information. Key summary point, aortic dissection, there are two types, type A and type B. Type A affects the ascending aorta, you treat that by immediate surgical repair. Type B affects the descending aorta, you treat that by medical management by lowering the blood pressure. So that's going to be it for today.